Good morning, good afternoon, and good evening. Thank you for joining us today for the webinar on CMS Interoperability and Prior Authorization Final Rule. Today's webinar is organized by To The New. We are a digital technology services company founded in 2008 with headquarters in Singapore and delivery centers around the world in Australia, India, Dubai, and US. The mandate we are going to discuss today is a regulation issued by the Centers for Medicare and Medicaid Services, in short CMS, and the mandate was issued in January last year. CMS gave payers time to update their ID systems, but also set clear deadlines to ensure compliance. Most provisions of this regulation start taking effect in 2026. This new federal rule mandates health insurers to speed up prior authorization, share data electronically, and make health information more accessible. The purpose of today's panel discussion is to provide concrete and practitioner-level insights on the rule's industry-wide impact and also challenges and opportunities with it. Please post your questions in the chat window at the end of the session. We will try to respond to as many questions as we can within the remaining time. Now, starting with introductions, my name is TK Verma. I joined To The New about 6 years ago as the business unit head of our Americas business. In addition to managing P&L of the business, I also lead our Healthtech competency. Joining with me today are Chris, Dave, and Vivek. Chris Ellsbury is the Chief Technology Officer at Janus Health. Over the past 20 years in his career, Chris has developed scalable healthcare technology solutions. He has led product development at FinThrive, TransUnion Healthcare, and Healthcare Payment Specialist. Dave Hodgson is the CEO of 2020 Insights. Previously, he helped healthcare organizations unlock operational efficiency through AI-driven automation. With extensive experience in digital transformation, P&L optimization, and leadership development, Dave focuses on solving foundational challenges across the revenue cycle, patient engagement, and care delivery systems. We also have with us Vivek Goyal. Vivek is the CEO of Wellness Connection, a remote patient monitoring company transforming care delivery through technology. With 25 plus years of experience across healthcare, AI, and digital innovation, Vivek has led strategic initiatives at United Health Group and co-founded multiple startups. With that, we're going to kick off today's session now. I would request our admin to post the first poll, please. And we'll keep the poll on your screen for about 15 seconds, so please respond to it. Thank you. So starting with our discussion, the first question I want to pose to Dave. Dave, what do you think? Will the automated prior authorization truly reduce administrative burden or shift it?
Yeah, thanks, TK. Well, we know that automation promises efficiency, less paperwork, fewer errors, faster turnaround, but it risks shifting the burden if providers must fundamentally overhaul systems, retain staff, retrain them, manage payer-specific integration. So early implementations might feel like extra complexity before the real benefits kick in. Fascinatingly, CMS has billion-dollar predictions of savings. So that's 10 or 15 billion dollars over 10 years is the prize, but there might be quite the fight to get there. So automation can kill the paperwork, but only if it doesn't digitize the pain.
So in your view, it will truly eliminate or reduce administrative burden, not just shift it from one place to the other, one participant to the other in the industry?
Well, yeah, I mean, just empirically, it can, because you know that across every provider organization in the land, there is a manual, paper-based shuffle to get all of the prior authorizations done. And it's super diverse and it takes a long time. And interestingly, the mandate actually imposes prior authorization within 7 days. So 7 days is like a stretch, which is 72 hours for expedited, which is sort of ludicrous that it could take more than that amount of time because it's such a fight back and forth and so forth. So in this new rule, what we're hoping to get is not only APIs, but the automation to take some of the paperwork and the faxing and the chasing out. But there's another piece, which is a little more cooperation between provider and payer, not just the back and forth fight that it is now. So there's quite a lot of fundamental change in that the workflows, the staff operating the workflows, the technology implementation to actually plummet, and then some new perspective on getting it. But again, massive automation, improvement in patient care, and a lot of savings is the prize. It's just the pain and the work is considerable.
Yeah, and then there is that word fax we don't hear much about these days, but this is one industry where they still have their business going, so good for them. Chris and Vivek, would you like to chip in with your thoughts?
Yeah, sure. I agree with what Dave said. I think it's definitely going to improve the efficiency after the initial pain, but I'm hopeful that it doesn't just move the problem downstream, where if the prior authorizations are accepted, there's more delays for payment for requests for information or denials. So hopefully that problem doesn't just shift downstream also.
Yeah, let's hope for that. You're right, Vivek.
I would just add that given the multi-payer and multi-provider model in the United States, it's the bigger ones have the resources and a lot of the capabilities to kind of still meet the mandate, but there are also smaller provider groups as well as like rural hospitals and others who are trying to sustain themselves in this high cost inflation market. So having those support to invest is not available equally across the board. So that's another challenge to keep in mind, that okay, there is a lot of treasure at the end of the rainbow, as Dave has been talking, but there's a lot of upfront investment which not many payers and providers may be able to bring together either.
Well, money is going to be cheaper starting yesterday with interest rates cutting, so hopefully money will go, investments will come in. But thank you, Vivek and Dave and Chris, for your responses to this question. I'm going to move on to the next one. And Vivek, I'll pose this question to you. So what operational, clinical, or cultural changes are required within payer and provider organizations to meet these regulations? And how can technology help?
Great question, TK. So it requires definitely a very holistic, integrative, and disruptive change to get this going and becoming commonplace in the healthcare industry. If we look at just the operational side, right, both the payers and providers must implement and/or upgrade their EHR and health exchange systems, basically, from what it is available today, so that it can work seamlessly across multiple different providers, multiple different proprietary systems, and so on and so forth. It should be compatible to some of our common HL7 or FHIR framework, which unfortunately, as we work across 600 plus EHR systems, most of them don't even are compatible to begin with HL7 or FHIR. So again, the bigger ones, we have it. Smaller ones, there is still a lot to get there. On the clinical side, again, the rule encourages alignment between payers and providers, where the treatment decisions need to be more data driven and evidence based instead of just administrative processes and steps, which is again a big mindset shift where you are not just clicking a button or going through the motions basically, but understanding the decision support and helping the patients getting the right treatment decision in the right time. Cultural change is one of the bigger ones. Traditionally, payers and providers, like working in some big healthcare companies, they look at each other at a very different lens. There is definitely much mindset shift is required, where both need to embrace a more collaborative approach instead of, I guess, sometimes a little more confrontational approach, and help each other reduce that silo by creating a bridge, so to speak, through the technology. And that's where the technology role is so critical in doing any of this, whether it be the implementing AI driven tools or automated workflows or secure data sharing, and within the realms of HIPAA high tech. Providers need to utilize more decision support tools, as well as ensure that the information submitted for the prior authorization aligns with evidence-based clinical guidelines. On the payer side, they need to have more robust APIs and digital portals so that it helps take away the administrative burden on the provider side. So it's a handshake where both need to kind of take some steps to meet in the middle, if you will, to get this going.
Thank you. And you think the technology services company like us or internal technology groups, they could help by standardizing interfaces using, let's say, FHIR, and build between big players, and then that should also help the small players who are participating with the big guys.
Absolutely, TK. I think there is a big gap in terms of what is required and what we see in some of the smaller and medium provider groups and even smaller health systems, basically. That in those cases, they don't necessarily have the capability or have the ability to invest to bring up or build out their own technology teams to help through this. This is where companies like To The New come so much helpful, because based on your experience, you know exactly how the communication channels work, what integration plays, what APIs to use. So instead of them trying to invest in a build version, a buy version is a way to go, and leveraging and essentially collaborating with teams like yours to make this bridge this silo.
Yeah, thank you. Idea was, by the way, not to run a commercial on To The New. Thanks, Dave and
so slick. It was so good.
Anything you want to add, Chris or Dave?
Yeah, I agree that for the smaller, middle, even some of the mid-tier and larger providers, that finding partnerships is probably going to be the route for success.
Yeah, Vivek's spot on, because you can't bolt this on. You have to fundamentally rewire it. And it comes with multiple threads. It's an API implementation at the low level. It's redesigning some of your workflow and your staff at the sort of middle tier. And at the high level, there is a cultural element here of not just fighting the usual prior auth system, but actually sort of working with it. So there's these multi-threaded components. And that doesn't happen overnight. So this is a fairly enormous amount of work to be done. Again, back to the payoff is great if you can get it, but the investment needs to be happening right now if it isn't, because, as we'll talk in a minute, it's all coming.
Thank you. Very interesting. Next question, Chris, I'll ask you. How are commercial plans dealing with this mandate? Are they voluntarily adopting it? And are they anticipating any ripple effects of this mandate?
Yeah, that's a good question, and I don't work for a commercial plan, but I can tell you what we're seeing. We're really seeing that commercial health plans are approaching the mandate from varying levels of adoption. Some of the plans are ahead of the curve, and some have already started aligning the prior authorization process to the mandate. For those players, I think the final rule really represents a chance to standardize and scale what they've already done. We see just a few of the payers beginning to implement like FHIR APIs for authorization. But what we really see is a lot of the payers that have started embracing APIs using non-FHIR based, none of the non-standard implementations to identify if the authorization is required or if certain items or services are also for the are required for the authorization request and response. Even when we see these, the more complicated procedures are still typically web-based portal navigation for an analyst at some healthcare provider in order to submit those authorizations. I think other insurance plans are really taking a wait-and-see approach. Resourcing is an issue for many of them. They don't have the time or the people, and some of those are looking for partners to assist also. And then many of these payers are going to have to make substantial updates to their current processes, to really hit the mandate. They're going to have to move those portal-based authorizations to APIs. They're going to need to move APIs, to comply with the interoperability standards. The specific authorization documentation that needs to be provided is probably got to be normalized. And then they're going to have to improve existing workflows in order to meet the timely requirements. Additionally, we do expect the commercial players will align on the 72 hours for the expedited authorization requests and the 7-day rule for others. But as I kind of mentioned before, I think it's likely that the payers are going to deny or delay payment for any type of service that is different from what goes into the authorization. So what that's really going to mean for providers is they really need to increase the focus on submitting high quality, like clinical documentation bundles with those authorizations, so that they don't have those downstream payment issues. And then there's certainly going to be the ripple effects for the payers that are implementing this. They're going to have increased efficiency. Their workflows are going to be streamlined, to get these things done quickly. They'll have fewer people in the mix on the authorizations. And then the technology improvements, many of these plans are going to need to invest in new IT infrastructure and probably to add AI in order to manage the timeliness rules.
That's a good ripple effect. I'm glad to hear that private plans are not just trying to avoid it. They are actively participating and anticipating and working on it. Dave?
Yeah, and I would sort of say that, the way to look at it is also that mandates really force a parity. And if you don't do it, your competition will. And so, sort of predict that plans that really embrace this new interoperability will win the provider's trust and retain that market share. So really, if thought is strategically, instead of being sort of reactive to this rule, you got to get there, else there'll be penalties, really there's enormous opportunity for provider partnership and for efficiency. And so I think the plans that are thoughtful and leaderful can really get ahead and sort of retain that trust or build that trust and keep that market share.
Thank you, Dave. Let me request Noel to post second poll at this time. Noel, please go ahead. I'll leave it on for a minute this time. I want to give everyone a chance to respond. Okay. Thanks everyone for responding. Next question to you, Dave. What will be the impact on defaulters for deadline?
Yeah. We know from this rule that non-compliance risks penalties. It risks exclusion from Medicare Advantage and from Medicaid, payment delays, and also reputational damage. So CMS may allow some grace. It has done in the past. It typically does that. But any organization betting on leniency risks quite a bit of financial instability and delays in patient care. So there are some reasonable teeth to this and consequence if the rules are not met. The problem is that many providers are still on manual workflows, and so back to the change is considerable and the teeth of this are considerable. So if you miss the deadline, you don't just lose money, you may lose credibility, and grace periods really aren't a strategy. A good amount of preparation and investment is. So if you're lagging behind, it might cost you more than fines. It might just also cost you revenue, may cost you, back to my earlier point, might lose you trust and credibility as well. So we'll see. I think the current view is that preparation is lagging behind, no surprise there. That some parties will be counting on leniency, we'll see there. So it's one of these things go in effect at the beginning of January, right? So certainly for the things, drugs come later. But we'll see how many are prepared at the time and then how forcibly CMS applies these penalties and or payment restrictions. So we'll see. On paper, they're quite severe and the amount of work to implement them is quite considerable. So we're talking about a very big deal.
But in the past with similar mandates, laggers have asked for a longer grace period and tried to negotiate by screaming. Do you think something similar could happen this time?
I would expect so. I do believe, though, that all parties want more efficiency. And there's no plan that I'm familiar with or provider system that I'm familiar with that wouldn't love to reduce labor costs and wouldn't love to improve patient care at the same time. Just give me a path to it. So I think there's motivation there. The question is back to what Vivek said earlier, is there competency to do it and investment to do it? I think that the other element here that needs talking about, again, Vivek raised it, is the vendors, the EHR vendors, whom really are at the forefront of most clinical pathways, most clinical workflows runs through the chart. So it'll be very interesting to see how many of their bigger vendors are agile and thoughtful enough to provide the ability to really implement these Firebase workflows or Firebase APIs to plumb the workflows so that the clinicians are really just thinking about adoption of new workflows and training. That's the ideal state. So the big sort of unknown here is not necessarily completely payer provider. It's also the technology infrastructure, which is mostly vended by the Oracles and Epics and all the rest of them, the Athenas and all the good friends. So to really understand how ready folks are, is I would want to almost survey the product roadmaps of those and see how much gap filling the provider has to do or payer has to do in addition.
Vivek, Chris, anything from your side?
I think David's spot on. There is definitely the stick and carrot approach, but the carrot is not like that $10-15 billion over 10 years across the system. If you think about the cost and the size of healthcare system, it's essentially minuscule compared to the upfront cost that each provider and the payer group, again, more the smaller and medium tier, have to put forward. Yeah. So it has to be incentivized more, I guess.
And there's no provider group you couldn't assemble in a room and say, hey, would you like prior auth to go more smoothly, more predictably? And not a single person would argue with you on that, especially for more sort of serious diseases. And there's no administrator in a provider who said, would you like to reduce labor costs and get that answer to the patient about how they're going to move forward with treatment as fast as possible? They'd all say yes to that. There's also, I think, on the payer side, when I've worked in medical management in plans, yeah, we'd love a better way, a more uniform way to manage all of this stuff. So I'm sort of bullish. I think it's the right direction, 100%. It's just the usual thing in healthcare, which is you got to have the financial incentives, which I think we do have here, and you've got to get these laggard technology infrastructures, which today, when I was at One Medical, like I just couldn't believe how much faxing we were doing, and how laborious and wasteful that is. So, healthcare lags, 2 steps behind the internet, sort of generalized, internet infrastructure. So this, I hope, pushes much harder into automated workflows and, having the APIs be sort of the liquidity of data across the healthcare system. That's the dream. And what you'll get, again, is labor savings, and you will get much, much more improved patient care when you do this. We should be there.
And Dave, you would be surprised, like when we are doing prior authorization on behalf of some of our clients, right, and provider groups, sometimes it gets denied, and to appeal it, we actually need to mail, like not even fax.
Yeah, I know.
100 pages plus of documents to just because they will not even accept. Forget about APIs, not even and to kind of send your clinical records in. So I'm like,
sometimes I say, you think going to the DMV is inefficient? Just look what happens behind the scenes in healthcare. It's nothing, and that's because, again, you got to have aligned financial incentives. There's some financial incentive, as is so famously now understood, behind delaying authorization for certain types of care, because there's a spectrum of appropriate consumption of care decisions made by providers. There's also a volume of overconsumption, of too much volume being ordered inappropriately. We know those are cases. Disease type and different providers and so forth are contributors to that. And we also know that there's strong incentive. This is famously understood with United Healthcare of their claim denials being like up around 30%. And we know there's financial incentive for that to happen if the patient is not really sort of in charge. So this is why this rule is potentially very elegant. If, again, the teeth are appropriately applied, that penalties and non-payment from CMS is real. And I think there's enough Medicare Advantage plans that are lucrative to both provider and payer that leverage will really be the test here. And again, I'm bullish that as long as the vendors come along with, which again, there's financial incentive, soft financial incentive for that, we'll see some good things. I think we really, really will see some good things. And we'll see the stories in certain markets where there's really good provider-payer collaboration. Again, I'm more familiar with the Seattle market, where I've seen really good examples of that, where there's great efficiency, there's great cost savings in the labor, and then you do get much more expedient patient care.
Yeah, thanks, Dave. I'm going to move on to a topic which is close to many people's hearts, especially as a consumer. Definitely is my favorite topic, and that's value-based care. So, Vivek, your product supports moving towards value-based care. So, how do you think this rule can unlock opportunities for value-based care and population health?
Yeah, so I think value-based care is where the overall push is on healthcare, right? Moving away from fee-for-service, which is more utilization-driven, to value-based, which is where more outcomes-driven, right? And in that model, where the provider is at risk along with the payer, that kind of is the first step. Like, you are forced to collaborate. It's no longer me versus you, it's we together. So that's the overall framework of value-based care and the population health. That is where this prior auth rules will make a ton of sense, because few different things that will happen. I'll start with we talked about the financial incentives, the cost savings, right? By automating the administrative tasks, both the payers and providers will have the opportunity to lower their ops cost, also reinvest that savings into improved patient care, which is where will lead to better outcomes of the patient population and will yield better financial incentives and bonuses for both the payer and provider in the value-based system. The improved coordination, again, we talked about the cultural mindset. Again, if you're part of the same team, you are in it together. So the coordination is bound to improve, and the passing of information in a more real-time basis with clinical records to everything about the particular patient and the patient population will help the people getting right treatment at the right time. And again, the right is key here, because not over consuming, but doing the right amount, doing the appropriate amount, because nobody is getting incentivized to do more testing or more prescriptions here like you do get in a fee-for-service system. Obviously, the reduction of delays will help in appropriate and timely decision making. And the best part around all this is the data transparency. Like I think Dave and Chris mentioned a ton about the healthcare vendors, the EMR system manufacturers and services coming along the way. But if the payers and providers push it, that this is the basic thing I need before I can renew your contract or I will get you in my door, they will be bound to do it. And that can only happen when the payers and providers are all looking at it from the same lens.
Chris, I think.
I would say, one of the other things from the value-based care that I think, I'm not an expert on the value-based care, but there's probably going to be an opportunity for physicians and physician groups that want to understand their MIPS and improve their MIPS scores with the API that's related to providing claim information. So I think that's another area that can help those groups that are involved in the value-based care. Understanding the downstream, where they've referred, what procedures are happening once they've referred those patients onward.
I've long dreamed of a time when the vast majority of revenue in healthcare in the United States is value-based, not fee-for-service based. And I think for us who've been in healthcare for a long time, have been always scratching heads why it hasn't happened yet. And you need it to be payer-driven, is that you're essentially pushing, and bundles are a great way, but bundles I think is one of the successful beachheads before you get to full medical homes set up. So bundles make a lot of sense. The challenge with it is you do have to change a lot of provider workflows. You have to change a lot of provider stuff, which is also plumbed by the chart. So you need, again, nothing moves in this country in effectively a capitalist society without financial incentive. And value-based care is a really good structure to do that. You have to have the technology come with it. So I've long argued you need two things to get this right. One is these kinds of incentives, these kinds of rules from the biggest payer in healthcare, which is the government, which is CMS, Medicaid, Medicare, Medicare Advantage. You got to have that entity say, I will only reimburse on these terms, which is what we're talking about with this rule and what we've seen with orthopedic bundles and other kinds of things. This is good stuff. We need more and more with this. And that's part one, is the financial incentive. And part two is you need the APIs. You need public APIs, because data liquidity is the fuel for value-based care alongside the financial incentive. When I know everything that's happening with a patient and I'm incentivized for outcomes, not volume, and I can get to the data, then all of this sort of comes along really, really well. But we need both of those, the financial incentives and the data liquidity, which again is often in the hands of Epic, Cerner, Allscripts, the friends, which, again, referring to my all my very good friends at Oracle, who I love dearly, that technology, a lot of these plans, I would say, with the exception probably of Athena, they're pretty old technologies and they don't move very easily or very quickly. And so there's still quite a lot of burden on the vendors to just even do the basics right before you even get to high-flung AI automation. Although, again, I know a little bit about what's happening in Oracle, and it's good stuff. So you got to have all of that.
Yeah, Oracle is a happy camper these days. I've covered all the topics wanted to cover. For the remaining 9 minutes or so, we can now take a few question answer. But before that, Anmol, could you please also post a third poll? Thank you. I have a question coming from audience, and I'll pose that to the group, whoever wants to take it. What level of cost savings can healthcare organizations realistically expect from implementing this rule? Anyone?
I think Dave kind of touched on this a little bit, but CMS has come out and stated that it's $15 billion over the next 10 years. Not entirely sure how they calculated that, but there's clearly substantial savings. The communication, standardizing the communication where you have people frequently manually navigating portals, or they have automation that may be doing some of that for them, is going to have a lot of time savings that they can reinvest into their other processes for collecting revenue. And then I think the thoughtful providers are going to also implement some of the newer technologies to answer the questions that have to be answered, and not spend a lot of time manually reviewing medical records to go put the information into the auth request that's needed. So they're going to save a lot of money there. So time savings, reinvested time savings, and a lot other processes that aren't just part of the communication that are more streamlined.
You can do some really interesting sort of back of the envelope math. You can say, well, how many people request how many prior authorizations per day, at what manual step and time taken to submit the claim, the authorization, how much receiptful time is it on the plan, review the rules, send back something, back and forth, have secondary opinions, blah, blah, blah. You add all the labor cost of that up, multiplied by plan, multiplied by provider center, or whatever, clinic or outpatient clinic, whatever. Multiply that up, remove then how cost of implementation for this new thing, and how much savings there will be for that, and then factor in whatever penalties you would occur or non-payment you would occur if you didn't do it. That's the essential math of what this is to get up to whatever this ludicrously large 10 billion number. Because I think that can compound very quickly. I don't know that folks appreciate how much prior authorization is happening all the time. That procedures, and I mean, we haven't even talked about drugs yet, because that's in the next phase of this. When you start talking about, is my chemotherapy approved or immunotherapy approved, before I even talk about my colonoscopy, there's just enormous volume of prior authorizations happening. So if you make that even 10% more efficient, I mean, this could be greater than that. You've got a very, very massive amount of compounded improvement. Again, we're just talking about dollars here before we even get to quality, because when you get a faster turnaround of, if this procedure is authorized and can happen, can I get my MRI? The amount of patient care improvement you get now for not waiting around for days or weeks, as this, whatever disease is progressing, you get some answers and you get some treatment. You get a whole ton of benefits. Again, this is all speculation, and there's some. Again, we can do all kinds of pro formas on what this could be. you just know if implemented broadly, good things.
Yeah, thanks.
Dave, that's a good point there. Also, I've heard from a lot of customers, situations where people have foregone care. They've been referred somewhere to go do a procedure, and then something doesn't get done timely, or it doesn't happen, doesn't get scheduled. Procedure doesn't get scheduled. It's not an emergency procedure, so they don't have the immediate incentive to go take care of it. And then that could compound into other problems later.
Huge deal. Yeah. As you know, I used to be the chief technology officer at One Medical Group, and this is one of the things we would track all the time is effectively abandoned referrals and abandoned scripts as well. It's sort of amazing when you tighten up those flows. When we went from regular prescribing to e-prescribing, just the amount of compliance we got on people taking their pills was sort of insane. And then we started putting referral notices and appointment making in the app. When you sort of close the loop for the patient, make it much more fast and efficient, people tend to abandon those things a lot less because they're more handheld in the process, which is what they essentially crave. So you get, again, and if you're in value-based reimbursement, all the benefits.
Thanks. I'll take one more question. We have many questions coming through the chat window, but I'll take the one that I'm finding interesting. So many healthcare organizations still rely on legacy systems. How realistic is it to achieve interoperability within the CMS timeline? So going back to the 6 months, all we have. How realistic is it to make all these changes? It sounds like a lot of work.
I can take that. It's definitely a very uphill target, basically. Now, obviously, if people are now realizing it, and I think Chris and Dave won't mention in their thing, if you're not started to think about it or work at it, then we're pretty much delayed. It's not going to happen over the 6 months. But that's where I think there will be some grace period. But the idea is that if you have not started doing it, you need to start doing it right as of today, because there is not much time. Even with the grace period, working in healthcare for a lot of my career, some of those systems are really outdated. So to try to get it up and running with the newest forms of technology, some of it will just come back and say that, you know what, you need to rip them apart and build it from scratch, basically. So that is the first evaluation or analysis that needs to be done, based on each group or each provider and payer, which systems are even ready to move forward with this mandate versus which ones need to be redone to begin with. And the more you have on that redone list, the more time it will take.
Yeah, and the thing is, intuitively, for the amount of change we've just been discussing, and you got 6 months left, it's not enough time to get even close to, let's say, 80-90% of systems. It's not going to happen. So why are we there? One, because the change is quite considerable, both technological, cultural, and workflow. And there's a whole bunch of dependency on the vendors. And I would say CMS has a very long history of bold mandates that get flexibly softened. So we can even talk about, ICD-10 shipped twice, Healthtech, phase 3 got completely softened now. So you end up in this situation very commonly where CMS says, boldly, we need this. You listen to all the three of us. We're super, we've got to have this. It's so good for patients. It's so good for cost. We want it. But then the rubber meets the road of reality inside of payers, vendors, and providers. They're all screaming, look, hey, we're just trying to stay margin positive and just basically take care of our patients. And you want all of this change? Hold on a second. And so you get this sort of loud noise of pushback. Look, it's too much. You got to slow it down. CMS responds to that, and then the penalty sort of gets softened. So there's a back and forth that we've seen before. We'll see it again. You just got to sort of hope that over time, which it sort of does, it gets incrementally better, even though we all want sort of overnight this to be much better, much quicker, more quickly.
Thanks, Dave. Well, gentlemen, all good things come to an end, and so does this discussion. Thanks to our esteemed panelists for taking time out of their busy schedules. Also, thanks to all the attendees. Hopefully, you take something valuable back from today's discussion. We will be following up with you and also sharing recording of this session. Please use that email thread to communicate with us. And also apologies for not being able to answer all the questions. We'll surely be responding to all the questions via email. With that, thanks again. Enjoy your rest of the day and evening.